Hello, everybody, and welcome. We are so delighted that you can join us today for Real Talk on liver cancer. My name is Dr. Mark Lewis. I am a medical oncologist. Specifically, I'm a gastrointestinal oncologist. So I treat exclusively cancers of the gut and adjacent organs, most importantly for today's discussion, including the liver. And while I am the director of gastrointestinal oncology at Intermountain Health, a multi-state healthcare system based in Salt Lake City, Utah, I want to be clear that I'm speaking today as an oncologist and actually as a cancer survivor myself. I had a form of pancreas cancer 7 years ago. So I hope to bring at least some empathy to our discussion today. The more important participant in our conversation by far, though, is going to be my partner, Tony Villiotti. And we'll get to see Tony in just a second. Again, this is a One Liver to Love Facebook Live event. And this whole Real Talk series is brought to you by Blue Fairy, the Global Liver Institute, and ASI Incorporated. Before we begin, I must mention that this event is brought to you by ASI. And although my fellow panelists and I are receiving a speaking fee from ASI for this program, we really wouldn't be here if we weren't passionate about educating people about liver disease and liver cancer as part of the One Liver to Love campaign. We have to be mindful of FDA rules on communication. So if you post comments or questions via social media during this event, please refrain from discussions about or direct or indirect references to specific therapies or drug names. Additionally, this presentation is intended for US audiences only. As this Facebook Live event is an educational disease awareness program about liver cancer, we will not be providing any clinical guidance or diagnostic advice. If you have any specific questions about your health or symptoms, or are seeking medical advice, please speak directly with your healthcare team. And just a little about the One Liver to Love campaign. The mission of the One Liver to Love campaign is to educate, provide advocacy resources, and create a community for those who have either been diagnosed or have a loved one who has been diagnosed with liver cancer. So with that, I can't think of a better segue to really the star of today's show, my partner in conversation, Tony Villiotti. Tony, so happy to chat with you today. Please go ahead and introduce yourself.
Thank you, Mark. I'm very excited to be here. This is a very timely topic, and it's a topic of great importance. My name is Tony Villiotti, and I'm from Pittsburgh, Pennsylvania. My liver disease journey began in 2005. I was 59 years old. I was retired. I had type 2 diabetes, and I was overweight. I was told I had a fatty liver. After about 9 years, in 2014, I was told I had NASH and also cirrhosis. At that point, I was referred to a specialist, to a hepatologist. Within 2 years, in 2017, I was diagnosed with liver cancer. In 1 year to 1 day, and 1 day after my cancer diagnosis, I received a liver transplant. After my transplant, my wife and I formed a nonprofit called NASH Knowledge, now known as Liver Education Advocates, to increase awareness and provide education regarding liver disease.
Well, Tony, we're obviously going to dig a little bit more into the details of your experience. And just from the start, I want to thank you for sharing. As you know, one of the hallmarks of medical ethics is we really try to preserve patient confidentiality. And what that means is when a patient like you is brave enough and candid enough to share of themselves, we really should acknowledge that you're giving us a gift. And that gift is sharing of your own experience. I often tell my patients that as much as we talk about clinical trials, each and every patient, even if they're receiving the standard of care, is essentially an embodied researcher who helps oncologists manage other patients better. And you are part of that today. So again, thank you for being so transparent. I just want to provide some bullet points to kind of outline our conversation. Tony, I think this will be helpful to kind of frame things for our audience. So you and I are going to talk about the initial experience of diagnosis. We're going to talk about posing questions to your doctor, which is an interesting way of kind of changing the conversational flow. And then we're also going to talk about how to improve communication about your own health with your family. And you and I are going to talk about sort of how you become a necessary messenger who has to relay information about yourself to your loved ones, which is sometimes actually an added onus of responsibility on top of all the things you're dealing with medically. So let's go back to the beginning. You gave us a very kind of small snapshot of how you went from sort of some what we call pre-morbid conditions, some risk factors for liver cancer, to then finding out you had liver cancer. And then you said in a relatively short order how you prepared for and received a transplant. I just want to say again, we're so lucky that you're enjoying, I hope, good health. And thank you again for sharing of that. So let's talk about the time of diagnosis. And again, I want to really put this in perspective for our audience. So we love acronyms in medicine, and you're going to hear several of them today. So hepatocellular carcinoma, or HCC, is the most common form of primary liver cancer. What that means is that word primary, it means where the tumor first starts to grow. So if it's a primary liver cancer, it means the tumor actually started in the liver. This is an important distinction because in my general practice, which includes diseases like colon cancer and pancreas cancer, those cancers can absolutely metastasize to the liver. But that's secondary involvement of the liver. What we're talking about today is primary tumors of the liver. And HCC makes up, by that definition, more than 90% of primary liver cancer diagnoses worldwide. So with that background, Tony, tell us about your reaction immediately after you were diagnosed with HCC.
Well, my immediate reaction was, are you sure? About 18 months earlier, I'd received a false alarm where I was told I had liver cancer, HCC, and it turned out I didn't. Apparently, there was a false reading on an MRI, whether it was a shadow or whatever, I don't know. But subsequent MRI did not show any indication of liver cancer. So first, I needed to be assured that they were right this time.
Right.
That we weren't going down a similar path. So once they did that, the reaction, my next reaction was, okay, now what do we do next? And the idea of a transplant was raised. I was kind of resistant to that. For most of my adult life, I've been concerned about diabetes, and I had read that after a transplant, your diabetes gets worse. So I raised that concern, and my hepatologist said, "Well, we can treat you for diabetes. We cannot not treat you if you're dead." So that kind of put the everything in perspective, and all of a sudden, I was a big fan of receiving a transplant.
Yeah, that's pretty bluntly. So you were given sort of a binary there, if you will, about yes, you could be concerned about diabetes, but we should also be concerned about mortality. Tony, sorry to interrupt you, but before you go on, there's just several things I already need to unpack. So you gave us again the timeline from diagnosis to transplant. It sounds like transplant was actually sort of vetted as an option for you very, very early on. But even before that, I actually want to dig into a little bit your need for confirmation. So you had this kind of boy who cries wolf phenomenon where you wanted to make sure that MRI or any other suspicious finding was actually confirmed to be cancer. I will say, and I don't know if you're aware of this, I suspect you are, but for the audience's sake, in almost every case in oncology, when we are making a diagnosis, an oncologist like myself will almost demand tissue. And when we look at something under the microscope, that's the ultimate proof whether or not someone has cancer. What makes HCC a little different, actually arguably a lot different, is that there are sometimes combinations, to your point, of how things look on scan and how things look in blood work that can actually convince us that a patient has HCC without that tissue confirmation. And that's a paradigm shift even for a doctor like myself, but it leads to this exact conversation that you're having where you kind of pump the brakes a little bit and say, hey, doc, are you really sure before I commit to this life-changing diagnosis, are you really, really sure about it? So I applaud you for even raising that. And I want to state for the audience, we are in the era of what we call shared decision-making. And what that means is in the past, and this was never right, but it was the dominant paradigm for a long time. In the past, a doctor like me in a white coat would walk in, and again, I'm not saying this was ever right, but they would basically tell you what you were going to do. And that's called paternalism, right? Me imposing as a doctor, not just by judgment, but a treatment plan upon you almost without your consent. And now, thankfully, I mentioned ethics earlier. Yes, we're going to protect your confidentiality, but we should also respect your autonomy. And that means giving you enough information that you can make a decision that's right for yourself. So, Tony, just really quickly, these steps that you had to walk through from diagnosis to transplant, how did that happen? Like, how were you sort of shepherded through those steps? Did it require more than one specialist?
Well, yeah, so after I was diagnosed with cirrhosis, almost exclusively saw a hepatologist, while also seeing my diabetes doctor as well.
Mhm.
But once I received the cancer diagnosis, then an oncologist
Yeah.
obviously came into the picture, and so the meetings after the cancer diagnosis were often involved both the hepatologist and the oncologist.
And appropriately so, as long as you feel again a part of the conversation. I like to tell my patients that they're at the center of a circle, and there's even participants around them that they may not even be aware of. So, for instance, if we present a case like yours at one of our conferences that we call a tumor board, what that means is doctors who you might never meet are actually almost offering you, again, discreetly, a second opinion because they're putting their eyes on your case and giving their input, even to the doctors who have direct impact on your care. So, Tony, again, you've gone so far. You've been so transparent with us so far. I do want to ask you this. How did you feel physically and mentally as you went through that year and a day between diagnosis and transplant?
Well, when I received the initial diagnosis, I was actually feeling pretty good. I had occasional episodes of what what initially we thought were dehydration, but may have actually been related to my liver disease. But um, but immediately after the diagnosis, the oncologist suggested that that I undergo stereotactic mm, body radiation therapy, which consists of five very targeted doses of radiation over a 10-day period. And the goal of that treatment was to prevent the spread of the tumor and to stop the growth. And is regarded as a bridge to transplant. So I underwent that testing, but as as time progressed, like I said, first, yeah, at initial diagnosis, I felt pretty good. Within about 5 months, I really began to feel the physical effects of the disease. I experienced ascites, had to have my stomach drained,
Mm.
also had to have my lungs drained. Fluid got into my lungs. And the worst of it was hepatic encephalopathy, where we had a situation where my wife came home one day. I didn't know who she was.
Oh,
Uh, and from that point forward, I had brain fog. And at that point, where I was experiencing all the physical issues, that's when I began to experience mental issues as well. Particularly as I got to the point where I knew I was getting close to the point where I'd be eligible to get the actual transplant. A lot of emotional ups and downs, which placed a great burden on my wife. She never knew which Tony was going to wake up in the morning. The
oh.
one who was optimistic and was planning a vacation after the transplant, or the one who thought he was going to die before the transplant and was writing his own obituary. So the mental burden was substantial. And I'm ordinarily a very laid back person,
Yeah.
and so my wife, it was kind of a new experience for her to see these emotional ups and downs. And as I said, you really place a great burden on my wife and my family.
Well, again, I apologize if it's painful even to kind of revisit that. And I'm glad that you brought up the fact that this particular disease and the fact that patients with profound liver dysfunction can be less clear mentally, that phrase you used, hepatic encephalopathy, that's really important actually for later parts of our conversation that really kind of dig into how do you retain the information that you've gathered about yourself and about your cancer and its treatment. I want to acknowledge your wife and all loved ones as what I call therapeutic allies. And I was thinking, the early days of COVID, so 2020 and 2021, it was extremely common that I would see patients either in the clinic or in the hospital specifically completely by themselves. And it was a case of you don't know what you've got till it's gone. I realized just how important those extra eyes and ears and hands to hold were at visits, because without it, the patient felt, I think, more vulnerable. They felt almost like it was just me and them, and they felt quite exposed. And I also felt like the burden of remembering everything I was saying was heavier on them. So, with all that said, Tony, do you have advice for people, and perhaps particularly men, because I think we're conditioned to be kind of shyer about these things, or less disclosing? Um, what advice would you have for patients to take next steps after receiving an HCC diagnosis?
Well, I think one of the important things, and certainly true in my case, was that it's important to have a second person involved in the visit. I know our situation was that after the visit, sometimes we had differing recollections of what the doctor had said. So it's helpful to have that second person in the room. My wife would. She was the note taker, and actually, getting back to men being more reticent about these things, she actually asked most of the questions. So we got to the point where after an appointment, she would write out notes about what had happened. We go over them, and that would typically lead to more questions for the next appointment. So we made a point of, when we walked into an appointment, we had a written list of questions for the doctor. And it actually reached a point where, when we walked in, the doctor would have her hand out for receive the list, and she was very good about going through the entire list. And after she got through my wife's questions, she would ask me if I had any questions. But it is important to have second person involved. It's important to plan for your visits. You only have so much time with a doctor. And I know my first visit, we kind of bumbled around, a bit, and it probably wasn't particularly fruitful. But after that, we learned that we had to be. I mean, you have to take charge of your health, and you have to get the questions answered that that are important to you.
Yeah, so if you don't mind, Tony, I'm going to take a minute and just kind of break things down from my side of the exam table. And I want to pull back the curtain a little bit on how a doctor's office, and perhaps specifically an oncologist practice, works. So in a given day, I might see between 15 and 20 patients. And that gives me about 30 minutes for patients I already know, and about an hour to meet new patients. And one of the things you said that I want to kind of expound upon is, I think we put a lot of pressure on the first visit. And that makes a lot of sense. When you're coming to meet an oncologist, the type of visit no one ever wants to have, the questions that are often forefront in a patient's mind are, are they sure about the diagnosis, like you already said? Can I survive this? How long can I survive this? And what is it going to take to help me survive this? So those are kind of all mixed together. And I'll tell you what I see as an oncologist is this phenomenon I like to call the tinnitus of terror, meaning that the moment I confirm that the patient has cancer, and it's totally fine to ask your doctor, are you sure? They should be sure. At that moment, it's almost like the fight or flight response kicks in. And when I think about how the brain works, all of our really sophisticated information processing happens in the cortex. It's a higher function of our brain. But fear, we respond to that much more deeply in what's called the amygdala. And when you're frightened, you're not going to retain hardly anything. So my experience of that first hour with the patient is, from the moment I confirm cancer, I can almost see them, even if they're trying really hard to pay attention, I can almost see them kind of go blank. There's something that behind the eyes, it changes. My point in all of this is, number one, note taking is absolutely critical. And we'll get to subsequent visits in a minute. But two, again, this is where it's really helpful to have someone along with you, not just for emotional support, but for information retention. And my point about not freighting the first visit with too much weight is, remember that when you meet an oncologist, almost always, this is the beginning of a series of visits that forms what I like to call the therapeutic alliance, meaning it should really feel like a partnership. It shouldn't feel like me talking at you. It certainly shouldn't feel like me forcing treatment upon you. But what I'm curious about, Tony, is, it sounds like you had your first visit and you realize, okay, we're going to have to approach this differently. And you and your wife came up with this method, which I love, of kind of preparing questions. But, between those visits, where were you going for information? Like, what resources were you and your wife using?
Well, after the first visit, of course, we went to the internet and we
Yep.
found a lot of conflicting information on the internet. So it really wasn't a satisfactory solution. Some of the information was just wrong. In other situations, there are people in one extreme or the other, where they had experienced unusual situations, or they had a very tame situation where they didn't experience much of anything. So what we after that initial attempt, we decided we really needed to rely on our medical providers. And once I was on the transplant list, we often consulted our transplant coordinator. She was the most accessible of the people that we had, and she was very good about finding the information that we needed. Either she knew the answer or she knew where to get it. We also consulted our hepatologist nurse. Again, he was more accessible than the doctor, and it was very helpful in providing information. So we found most of our information through through the medical system, but not necessarily through the doctors.
That's interesting. And I want to use your case, if you don't mind, as an example of a very modern reaction to a cancer diagnosis. So we have statistics here. Tony, we'll talk maybe about the meaning of statistics and how it helped you make decisions. But what I do know is that, and this stands to reason, 97% of patients, if they have access to the internet, once they have a cancer diagnosis, they will use the internet to read about cancer. And 94% of them will do exactly what you did. And I just want to acknowledge here how understandable that is. When your life is on the line, it completely makes sense to me that you're going to use the internet to sort of crowd search, at least initially, information about your disease. I think where things start to break down is how individually applicable are your search results to your case. And this is where it is very helpful to establish a dialogue with your care team, whether, like you said, it was your transplant coordinator or your hepatologist nurse. It doesn't necessarily have to be the doctors or the doctor. It certainly can be. But I think what I'd like to point out here is there's almost a false binary, I think, in some people's minds between what you're describing, which I would call self advocacy, and trusting your healthcare team as a reliable source of information. It can absolutely be both. In fact, my favorite form of dialogue with my patients is exactly what you've already described, where you and your wife came in with questions so that we can both get the most out of our visits. So, what I wanted to tell the audience again is time with your doctor is at an absolute premium. So, I will be very honest, of those 15 to 20 patients I see in a day, what I like to tell myself and actually tell my patients is when you are sitting in front of me, you should have my full attention. But if I'm very, very honest, in the back of my head, I also have a clock. And I know that, again, for a subsequent visit, you and I may only have 30 minutes. So there are things that we need to accomplish during that appointment. And I love the fact that you brought in the questions and you were not forward per se, but you were doing it so recognizably that your doctor would address those questions right off the bat. So let me ask you this, Tony. Did you have any reservations at all, even initially, about asking questions, or did you kind of fall into that pattern kind of naturally with your wife and your doctors?
Well, I had more reservations than my wife did. Let me put it that way. I tend, to be, you kind of sit back and listen to what the doctor said. Where my wife was much more aggressive about, if the doctor didn't answer the question satisfactorily. I mean, she would follow up, or I would, if it was just me sitting there, I'd be more inclined just to accept the answer and not follow up.
So I just want to acknowledge that again, we have moved on, thankfully, from the era where it was discouraged for you to quote question the doctor. It is entirely appropriate for you to question the doctor. And that goes all the way up to, doc, should I get a second opinion? I always like to say, if your doctor discourages you from getting a second opinion, that's actually even more reason to go and seek a second opinion. But it's more important than that. It's understanding your own health and the treatment decisions that you are a part of, that you are participating in. And again, this goes back to retention. So I don't know if this is common knowledge. I suspect it's not. One quality measure for how an oncologist performs is we are supposed to be crystal clear in the very first visit whether or not we intend or anticipate that you're going to be cured of your cancer. Pretty basic, right? You would hope to come out of your very first visit with an oncologist knowing whether or not we intend to cure you. And that goes in both directions. So you have some people that were initially pessimistic who are now more optimistic, and vice versa. And I just find that really interesting because you would think that nothing could be more crystal clear and stark than am I going to be cured or not? And yet, again, I think fear and all the emotions that go along with cancer have a lot to do with this. I think it can almost distort our memory. So, again, I think approaching each visit with your doctor intentionally, making sure that you and your loved ones get your questions answered, I think that's really, really appropriate. And again, Tony, I applaud you because you're telling us, even in this sort of dynamic you have with your wife as a couple, that she was, to use your own phrase, more aggressive. I would just say I think she was appropriately seeking for information about your health and that you don't need to feel like a passenger on this journey. You should feel like you're a co-pilot. Um, I want to pivot since we've mentioned your wife now a couple of times. I want to acknowledge the fact that when you're a patient with cancer, not only are you at the center of your own medical care team, you're also at the center of a circle that includes your family and friends. So, Tony, did you have any issues at all communicating with your family after your diagnosis, telling them what was going on with you, telling them what to expect?
Well, the big question after the diagnosis was when do we tell them?
Hmm.
Because I felt like when you first hear the diagnosis, and we were very fortunate. We walked out of our first meeting with actually a plan at the how to attack the disease. So I think so we I felt I could answer the curable question that if anyone asked,
Good.
but so it was a matter of when do we tell them, and we're talking mainly about our two adult children, and then what exactly do we say? So we waited a little while just because we wanted to have in our minds we didn't want to make it an overly emotional situation. I mean, they both have young children, and we didn't want to disrupt their lives unnecessarily. So we waited a little while, and then we did tell them. Initially, my wife and I together got on the phone and talked to them about it, and then as things progressed, it was actually mainly my wife who would update them, and they were more inclined to go to my wife for information because they didn't think I would tell them the truth. So they were more inclined to reach out to her to ask them how things were going, but and then the other people that we focused on were our siblings, and we told all of our siblings, individually about the situation. The harder part for me, communication wise, was communicating with my wife on a more or less daily basis on how I was feeling.
Yeah.
Because I guess in many ways, kind of typical guy, ask me how I'm doing, and always doing fine,
Yes.
and
Yes.
so I had kind of get past that, and the days where I was not feeling well, I felt I needed to express to my wife, you know, exactly how I was feeling, and if I knew why I was feeling that way, because
Yeah.
because I knew she was the main communicator actually with my doctor, with the medical team and the family. So she really needed to know what was going on. So I felt that, but that was tough. I mean, I'm just not, I wasn't used to doing that, and she would probably tell you today that I've reverted to my former self in that regard.
Well, listen, there's a couple of things to unpack there. First and foremost, I think it's important to acknowledge that you said, listen, we needed a little bit of time to process all this emotionally before we then relayed it to family. And I think that's very, very understandable. I actually think receiving a life-changing diagnosis like HCC, it's not unlike grief in the sense that you go through these stages. So again, this doesn't have to be perfectly linear or prescriptive, but I see people go through denial and anger and bargaining before they arrive at acceptance. And at that point, I think you're in more of a headspace where you can talk to other people with some sense of objectivity about what is going to happen to you. Um, I'm curious though, these notes that you were taking and these questions you were getting answered in visits, did that help you when you were communicating with your own family, or did it help your wife?
Yeah, I think it did. I did because it just, I mean, again, the passage, even a couple days later, you tend to forget what was said. So my wife actually kept a diary,
Yes.
daily diary of what was going on with me. So so if she didn't quite remember, or if I didn't remember, we always would just refer back to her notes. So it was very helpful to keep that record.
Yes, and listen, as an oncologist, I 100% second that. So, a couple sort of practical tips I wanted to share with the audience, Tony, if you don't mind. I have absolutely no objection to being recorded during visits. And again, as long as we're talking about being proactive and quote unquote asking your doctor hard questions, a very easy question right at the beginning is, "Hey, doc, do you mind if I record this?" We've never had more recording devices at our fingertips. You can even go a step further. And if you want to avoid the game of telephone after the visit, if you feel comfortable, you can also ask, "Hey, doc, can a relative join us either on the phone or even on FaceTime?" I actually find FaceTime helpful. There's something about the visual I think is very engaging. So these are totally fine questions to ask at the beginning of the visit. And then the last thing I wanted to say, Tony, to you and the audience is, almost every doctor these days uses an electronic medical record. And in fact, it's so common place that I've seen visits where doctors sit there and they kind of face the monitor and they type away and they almost ignore the source of all this very important data, which is the patient right in front of them. So, what if we take this computer and rather than having it separate us, what if it can actually be a form of connection? And this is what I mean. Almost every electronic medical record now has a capacity that I call or liken to secure email, where you can send me questions or even updates between visits. So, for instance, when I have a patient on treatment, say, it's very typical I might see them every 2 weeks. It's actually pretty uncommon. I see them more often than that. But that's a lot of time. That's a lot of life. That's a lot of treatment that can happen in those 2 week intervals. I call it a punctuated equilibrium, is where I get to see them. But there's all this stuff in the middle that really, really matters. So I would encourage you and anyone else listening to find out what facility you might have in the electronic medical record to communicate with your doctor directly. And I'll tell you, I don't view it as a burden. I actually prefer to know what is going on with my patients in real time. And back to your stoicism that you talked about, Tony, it's also a way, especially for men, to raise things that are difficult, maybe even scary, outside of that in-person visit that can have its own form of intimidation. So, for instance, if you're having a dark night of the soul and you're up at 2 a.m, immediately pre-transplant, wondering, "Oh my gosh, what does this mean for my mortality?" I answer messages like that when I come in the next day to start my practice. And so, I really think we've never again had more tools at our disposal to record visits, to involve family members who even aren't physically present, involve them virtually, and to really use these electronic medical records not as obstacles for our communication, but to expedite our communication. And along with that, I'll point out that for the last 2 years, the federal government has mandated that results be made immediately available to patients through these portals. Now, not every patient will choose to read the results in real time, but if they do, and if they have a question about a result, because you've already used some pretty complicated medical terminology in our talk today, like stereotactic body radiation therapy. If something is written about you that you don't understand, you shouldn't have to wait till your next visit to get that answer. That's something you can fire off as a message and we can get to it hopefully in a reasonable turnaround time. So all of this is to say, Tony, I think we have modern tools that can actually help communicate with one another. And again, even get over some of these obstacles that have traditionally hampered men and our ability to speak more freely about our health status. And again, just a lot of admiration for you and your courage and candor in sharing about that, because that's hard to bring up.
Well, thank you. And if I just interject, I think that is great advice. You're using uh, the your messaging system that many health systems have. I mean, I did not use it at the time. To be honest, I'm not sure if it existed or not at the time, but I do use it now, and I think that is great advice. That's a great way to communicate with your medical team.
And I'll go one step further. There's actually even proof from a pretty famous clinical trial that patients who do that have better health outcomes. Now, it may sound like I'm overpromising now, but if you think about it, if you're telling your doctor what's happening to you, what you're feeling, both mentally but also physically in real time, we can respond more quickly. And sometimes we can circumvent bigger problems that might be brewing and keep you out of the hospital, keep you out of the emergency room. So it actually, while it's wonderful for cultivating this two-way dialogue, it actually has proven medical benefits as well. So if that's available to you now in a modern medical practice, I strongly encourage people to take advantage of that. So Tony, I think we're at the time we need to start kind of wrapping up our conversation. Any last words from you, sir?
No, I just think if I had to give advice to anybody, including men, it would just particularly men, it would just be planning for your visits, taking notes, or you're recording as you suggested, and then just be open with your situation so you can get the support you need from your family and friends.
And I'll just say back to that and just to underscore, when you're the patient, you're the ultimate stakeholder. Nothing matters more than how you feel and how you do. And listen, I'm invested in my patients. Of course I am. We take on something we call fiduciary responsibility, where we want to act on your behalf to the best of our ability. But I'll be honest, at the very end of the day, it is still the patients who are ultimately the ones that have to deal with all of this. And I tell them that. I'm like, listen, I'm kind of viewing everything at a remove. And then finally, there's this wonderful phrase that not everything that can be measured matters, and not everything that matters can be measured. And what I mean by that is there's absolutely parts of this experience. You even talked about fear and encephalopathy. There's parts of this that I just can't quantify. I've got all these labs and scans and sometimes even biopsies, but unless you're telling me what you're feeling, there are parts of this that are going to be completely invisible to me as an oncologist. And so I think what we want to encourage today, and you've done a wonderful job of not just encouraging it, but exemplifying it, we want to encourage open dialogue. So be intentional with your time with your doctor, because boy, is it at a premium. Go in with questions and don't be afraid to ask them, and try to, as best you can, record the content of these visits so that you can retain it and then pass it on to loved ones. Um, and as a reminder, for those of you that are joining us live on Facebook and other social platforms, the One Liver to Love campaign actually offers conversation cards to help start what might be difficult conversations about HCC with loved ones and with healthcare providers. You can download these cards from www.onelivertolove.com to get started on improving communication with your family and your doctors about your diagnosis. And you can do that today to really help talk about HCC. After downloading the conversation cards, we recommend that you take the time to practice asking the questions with yourself in the mirror. I know it might seem strange, but it helps to rehearse. You can talk to your pet, you can talk to your friend, anyone that you feel comfortable talking with about your health. We really hope that these conversation cards would be a helpful tool to improve communication with your family, loved ones, and healthcare providers. Again, this is not the time to be a shrinking violet. This is the time to ask the questions that you need answered. And please, please, please feel no need to apologize for that. So this concludes our discussion on live real talk on liver cancer. And thank you again, Tony. Like, as much as I was really honored to kind of moderate this, the most important things that were said today came straight out of your mouth. And I so appreciate your willingness to share it with us. So thanks again.
Well, I was very pleased to be involved.
Yeah. And thank you to everyone who tuned in for our discussion. I hope the information that we discussed today was helpful and informative. I would like to thank ASI for making this event possible, as well as Blue Fairy and the Global Liver Institute for hosting the event. Please check out their websites. We'll add the links in the comments below, as they have some incredible resources for people living with liver cancer and for those who have a loved one living with the disease. The One Liver to Love website is also a great resource. And be sure to follow the hashtag One Liver to Love, all one phrase, on social media. You can also head to www.onelivertolove.com to learn more. Thank you, and have a great rest of your day.